Welcome to Medical Specialist Associates educational series on topics in anesthesiology. I'm Christopher Voss, MD, MS, a board-certified anesthesiologist, as well as being board-certified in critical care medicine, neurocritical care medicine, and pain medicine. Enhanced recovery after surgery protocols have been adopted in spine surgery to optimize patient outcomes and to speed up their recovery. This particular program will focus on key anesthesia management principles in the perioperative period, the intraoperative period, as well as the postoperative period, all in an effort to improve patient outcomes in spine surgery. We'll start first with preoperative considerations. The first is assessment for patients for comorbidities such as cardiovascular disease, pulmonary issues, or diabetes. Say, if a patient is an uncontrolled diabetic in the preoperative period, we want to have better management of that patient's diabetes prior to surgery to optimize their wound healing. Or say if a patient has undiagnosed or diagnosed obstructive sleep apnea, but is not using CPAP or BiPAP, allowing them to initiate that treatment in the preoperative period prior to surgery can greatly improve their wound healing in the postoperative period as they'll sleep better. We also want to focus on anemia management. As those of us know in this field, these particular patients can possibly lose a substantial amount of blood in the intraoperative period. By focusing on treating pre-existing anemia, say possibly with the use of erythropoietin or iron supplementation in the preoperative period, we can greatly reduce and hopefully eliminate the need for allogenic blood transfusions intraoperatively and in the postoperative period. We also want to focus on the patient's nutritional status, and in particular, their protein requirements. If a patient is protein malnourished in the preoperative period, they can have significantly reduced wound healing, and we want to address this then in the preoperative period. We also want to focus on smoking cessation. In particular, we want to encourage smoking cessation at least 4 weeks prior to surgery, and if needed, to supply the patient with, say, nicotine replacement options or other options to aid in smoking cessation. This will also greatly aid in their wound healing. We also want to focus on prehabilitation and education. Now, physical conditioning in the preoperative period can greatly reduce postoperative pain. So if a patient is not moving, and if they don't have an exercise program that works for them, allowing them to initiate one in the preoperative period within their limitations of pain can greatly improve their postoperative pain. We also want to explain the ERAS protocol to patients. By getting patients to understand what we're trying to accomplish with the ERAS protocol, we can get their buy-in. And in getting their buy-in, we can have better compliance with these particular techniques that we're trying to implement. And this can greatly improve a patient's postoperative outcomes. We also want to focus on minimizing fasting and carbohydrate loading, actually. So all too often in anesthesia, we have almost adopted this golden rule of an 8-hour fasting for all patients. However, ERAS pathways have recognized that clear liquids are allowed up to 2 hours pre-surgery, and this can help a patient maintain euvolemia. By maintaining euvolemia in the preoperative period immediately before surgery, this can help with intraoperative blood pressure management. We can also encourage carbohydrate-rich drinks 2 to 3 hours before surgery, and this can improve metabolic responses in both the intraoperative as well as the postoperative period. Now, we talked about optimizing nutrition by emphasizing protein requirements in the preoperative period. However, we also want to have a focus on vitamins C, A, D, and zinc, as well as iron supplementation to support healing. In the intraoperative management, we have several anesthesia techniques to consider. We can consider multimodal analgesia with the use of things such as acetaminophen, non-steroidal anti-inflammatory agents, gabapentinoids, and ketamine to reduce opioids. However, we can also consider magnesium and clonidine. Now, for those that might not be familiar with it, magnesium is a natural NMDA receptor antagonist, and so it itself can help reduce opioid requirements, or it can be particularly effective if it's used in combination with ketamine. Of course, clonidine is an alpha-2 agonist, and this in itself can have pain management benefit, as well as reduce the global need for opioids and reduce certain complications such as postoperative nausea and vomiting. We can also consider regional anesthesia techniques, in particular intrathecal morphine, or depending on the particular type of surgery, we can possibly consider paravertebral blocks. Notice here how I've deliberately left out epidural anesthesia. For the most part, epidural anesthesia is now frowned upon because of a significant risk of epidural hematoma. We should also consider TIVA. So total intravenous anesthesia can reduce nausea and vomiting in the postoperative period and can also help a more rapid recovery. In the intraoperative period, we also want to focus on lung protectant strategies, and in particularly we want to ensure to incorporate PEEP to avoid atelectasis. This is particularly important because patients are often prone for these surgeries. Now, in the intraoperative period, we want to consider controlled hypotension. However, this is a balance. You do want to have an adequate blood pressure to ensure spinal cord perfusion, of course. However, you don't want to have too high of a blood pressure because, again, as mentioned earlier, there can be a significant risk of intraoperative blood loss, and so by not having the patient hypertensive or a controlled hypotensive state, you can try to reduce blood loss. To accomplish this goal as well, we of course can consider antifibrinolytics such as tranexamic acid, to where it's common to give 1 gram intraoperatively, and to use cell salvage if it's available. So we also want to employ goal-directed fluid therapy to avoid volume overload and optimize recovery. Oftentimes, these patients will have an arterial line for the intraoperative management, and we can use things such as the A to A gradient on the arterial line to try to optimize whether or not a patient needs more fluids or not. Now, very often we will have neuromonitoring for these patients in the intraoperative period. And so the neuromonitoring can include MEPs and SECPs. And in these particular cases, using TIVA is particularly important, and we often use things such as a combined propofol and remifentanil infusion, and this can avoid signal suppression. We also want to limit or avoid neuromuscular blockers altogether, as this can interfere with neuromonitoring, such as MEPs in particular. And again, we want to maintain stable hemodynamics to encourage spinal cord perfusion. Lastly, if ketamine has not been used as part of a multimodal postoperative pain management strategy and intraoperative strategy, we can consider using ketamine intraoperatively to augment neuromonitoring signals. Now, in the postoperative period, we want to continue with our agents such as Tylenol, non-steroidal anti-inflammatories, gabapentinoids, ketamine, magnesium, and clonidine. But we particularly want to consider scheduling these medications to make sure that patients are getting them around the clock to reduce their need of opioids. We don't want to create a situation to where these medications are perhaps maybe PRN and a patient doesn't ask for them, and then ultimately they get an opioid when they didn't need it because these medications weren't scheduled. Now, the postoperative period is here reflected now in preoperative and intraoperative management, because hopefully we have thought about the use of intrathecal morphine or paravertebral blocks, because these techniques are largely not available in the postoperative period, so they need to be thought of ahead of time. And then of course we'll use opioids as needed. In particular, we want to focus on using oral opioids instead of IV opioids for their longer lasting effects. Perhaps what is not talked about enough is the need for sleep and its vital role in recovery. So what we want to do for patients is ensure a quiet, dark environment in the postoperative period, and we want to focus on non-opioid approaches because these all promote sleep. And if needed, we want to consider supplementation with things such as melatonin, or if we haven't used clonidine already for a multimodal postoperative pain control, we can consider clonidine to help improve sleep quality in the postoperative period. We also want to focus on preventing postoperative nausea and vomiting. And here it's particularly important to focus on a multimodal approach to where we use dexamethasone, 5-HT3 antagonists such as Zofran, and again, minimizing opioids, which can be associated in and of themselves with postoperative nausea and vomiting. In the postoperative period, we really want to focus on recovery and getting a patient to discharge so that they can continue their recovery at home and ambulate and sleep better in their own home environment. So we want to focus on physical therapy as soon as possible after surgery, and we want to set clear ambulation goals, not only for the patient's more speedy recovery and to ensure muscle mass for the patients, but also to prevent complications such as DVTs. Lastly, we want to really focus on resuming oral intake as soon as possible and to consider protein-rich supplements in the postoperative period, again to support adequate wound healing. And for the most part, we're going to base our discharge criteria on pain control and mobility. So this is another reason why it's so important to focus on multimodal analgesia as well as early mobilization in the postoperative period. We also want to provide patients with clear home instructions, and this is important to where we want to introduce patients in the preoperative period to the ERAS pathway, but then also make sure that they have clear home instructions, again, all in an effort to ensure that a patient understands the goals we're trying to accomplish to get their buy-in. So now, by applying ERAS principles in spine surgery, anesthesiologists can enhance patient outcomes, reduce complications, and improve recovery. Key components include preoperative optimization, multimodal analgesia, and early mobilization. To learn more about topics in anesthesiology, I encourage you to visit us at our website at www.med-specialist.net and to subscribe to our YouTube channel.